A 64-year-old gentleman with a past medical history significant for coronary artery disease, status post 2-vessel bypass, diabetes, hypertension, hyperlipidemia, who came in to a hospital in Tyler, Texas with chest pain, 4-day duration, typical anginal symptoms, and unfortunately hadn't come into the hospital. The onset of symptoms had waited at home waiting for it to improve, but unfortunately did not improve. Would someone mind taking a crack at this EKG? One of the first years, maybe? Omar, what do you think? Mm-hmm. Mm-hmm. Excellent, exactly right. So just like how Dr. Giroudi mentioned, there are ST elevations present over the inferior leads 2, 3 AVF, as well as reciprocal ST depressions, 1 AVF, and as well there's also ST depressions V2, V3, just like how Dr. Giroudi mentioned, concerning for posterior STEMI involvement, so inferior posterior STEMI. There also is a block pattern, and it looks very much like a Wenke block pattern. So the patient went emergently to the cath lab, where cath revealed a proximal thrombotic occlusion of his RCA, found the RCA graft chronically occluded and down. Importantly, though, the V-gram showed what appeared to be VSD apically. The patient, though, was not in cardiogenic shock at the time, arguably a little bit hypertensive, SVR in the 1700 range. There was no PCI done. Balloon pump was placed for afterload reduction, and a nitro drip started, and he was transferred here. So we have evidence, at least on V-gram, of a VSD. He's hemodynamically stable, but given the fact that he's 4 days out, we're concerned about mechanical complications. His initial echo here shows, just wait for it to load. Okay. Mm-hmm. Mm-hmm. Exactly, yeah. So we have inferior akinesis, depressed function, but really nothing provocative on this view. Let's wait for it to loop. On here we have evidence of some kind of an unusual pattern over the right side. It looks as though there's some flow and some maybe even a fluid collection lateral to the RV. So it's a little bit. Okay. So here we have LV, of course, RA, and here's the RV, and it looks almost as though it's a little bit compressed. There's this hypoechogenic area, as well as the RV, and it looks like there's some color present in this hypoechogenic area.
So technically, I'm sure there must have been a 2D image before this
Mm-hmm.
one, and so what you want to see is what are your margins of the RV that you're defining RV by?
So we're using this, that line is RV margin.
Okay, so what you're showing is the color in the, what looks like myocardial and going across the myocardium in the RV apex.
Mhm.
It would have been nice if that would have been pulse.
Correct.
So
Yeah.
what kind of phasing? It appears to be somewhat phasic. I can do it by slow. So can you tell me what is the phase of that color flow?
So it's a little bit fast, but it looks like it's a systolic flow
So to me also,
in this territory.
is the equilucency towards the base of the RV
Mhm.
that you see there.
And all this is in keeping with our concern about a mechanical complication. We have another another short axis image. This is at the apex, and it's unimpressive at this point in time. It shows a fairly preserved apical function. No pericardial effusion noted. If you go one level up, though, we get our diagnostic finding. Does anyone want to take a crack at this, at the short axis view?
Means first you have color with echo.
See it seems like thinning and potentially a defect in the ventricular septum.
Mhm.
First define
It's
it.
kind of flailing.
What level of view is this? Is it
Oh, the
transversal
capillary
short?
muscles. It's like,
Yeah, it's at the level of somewhere between the pad and the apex, so it's in the LV, parasternal view. Where is the defect you're seeing?
right in the middle of the septum.
So there is the neck or the opening, and then you see a cavity around that. And you can see the inferior wall, the PEP is not moving at all. That's it. But they didn't put color in this view.
Yeah, unfortunately, neither in the
So
previous
from
view nor
echo,
this one.
Technical point, the sonographers, when you see something like this is not normal. You have echolucency, you have a cavity, and you should put color there. And there was no color. This way, if you would have seen color, you would have seen it, a cavity that fills. You would have seen a shunt across that breach. Not shunt, but color flow across that breach.
And the velocities, you can actually use the modified Bernoulli equation to calculate the.
So, your Doppler angle here for velocities would be very perpendicular. You
Mhm.
want to be parallel.
Mhm.
But this would give you a good sense of the breach and that has been present, the pre-wall rupture that has been present. Now, when I see this, to me this looks like it's in the mid LV cavity, maybe towards the apex. So still, to me, it still doesn't explain the color flow that I'm seeing in the apex. Okay? So what should you be thinking when you see? You have to think this is a 2D view, it's a tomographic view. We are not seeing it in 3D. But if you think about 3D heart and you think about the inferior wall and the infraseptal wall and see how the free wall rupture occurs, you can potentially see how there would be a flow towards the apex and an aneurysm formed towards the apex. Go ahead.
So just like how Dr. Shah mentioned, there is a defect present here, pseudoaneurysm with tracking up and down the pericardium. And the clinical course at this point in time, once we have all this documented, the patient was upgraded from balloon pump to 501 Pella axillary, and actually did fairly well, was intermittently on BiPAP with good flows on Impella. The plan had been for a bridge to surgical repair with Impella in place. Unfortunately, about day 4 of his hospitalization, he developed staph epi bacteremia, creatinine started rising. But the plan was still in place to pursue surgical repair when stable. To kind of better characterize this lesion as it was evolving, a coronary CTA was done. that demonstrated, as stated, the large pseudoaneurysm that we talked about, neck 20 centimeters. And interestingly, at this point in time, there was also compression, inferior compression of the right ventricle, which is consistent with the findings they found on Swan-Ganz catheterization. There was also a 10 millimeter apical inferior VSD with shunting. This is one of the images from CT demonstrating the very, very large neck into the pseudoaneurysm. And this image shows very well the pseudoaneurysm and compression, actually, of the RV with the pseudoaneurysm decreasing filling.
Who wants to take that CT? Right?
Oh, we can review it some.
Who has done CT?
I mean, but this looks like a weird image.
This is
Yeah.
an off-axis view, so you
So
have
I'm
to-
going to ask somebody to explain to me. I would not have thought of this.
This almost looks like, to me, it's a four-chamber view, which is, I mean, if anything, I expect.
The only thing that does not make it four chamber is the ridge that you're seeing between the top cavity and the bottom on the right,
Right.
the RV and the bottom cavity.
Mhm.
But that's why I wanted somebody with CT to
Yeah.
comment.
This is-
I think Dr. Marian's thought that the neck was actually the one on top, and then all that pseudoaneurysm is actually extending all the way to the inferior border of the RV. So,
You
Paul,
want
if
to
you
show
just
me
mark.
what you're talking about?
I think this is actually a short axis view. It's just
Yeah.
distorted here.
That's the neck over here, and all this pseudoaneurysm has some septation here.
Mhm.
But this is
Okay.
all the collection, and this is the rupture.
Mhm.
Rupture.
Basically, it's a rupture kind of at the where the inferior wall meets the septum,
Mhm.
at that insertion point. That's what it looks like.
Yeah.
And ultimately, there was a repeat echo done on the 30th, given the fact that the patient was now in cardiogenic shock on pressors and intubated for pulmonary edema. So you can start looping. All right.
You can see.
So you can see that the neck has, the neck has widened. It's very extensive now. RV pressures are very high.
So if there
No, no,
wasn't
no,
a
no, no.
clear neck,
No, you're not that's not the neck. What are you,
So this is the pseudoaneurysm.
right, and that's your RV there.
Yeah, this is the RV present.
So you're seeing the aneurysm around the RV,
Mhm.
but your pseudoaneurysm was communicating
With the LV, yes.
So you have to understand these are
Yeah.
tomographic cuts, so you're not seeing the communication. So there is no direct communication between the RV and the
If you go
pseudoaneurysm.
back to your short axis view, go back to the CT image that you had before, right? And draw what would be a four-chamber, draw a line basically that goes through, at about a 45-degree angle. You'll see that you're actually cutting through the pseudoaneurysm cavity
Mhm.
right next to the RV.
Mhm.
So that's why it appears next to the RV, but it is not
Communicating, yeah.
with the
Mhm. Sorry, that was misstated.
How is it, why is it appearing over there then?
That's what Dr. Shah just explained.
Yeah.
Go back to
Go back
the,
Sorry.
do you want to,
just draw, put a pen at a 45-degree angle. Go back to your CT.
Mhm.
Between like 2 o'clock and 7
yes,
o'clock.
just do a 45-degree cut.
Put from 1 to 7 or something.
No, 2 o'clock to
You
7
want to go,
o'clock.
Mohammed?
Yes, yeah, you can see the line actually.
Yeah, you
Yeah.
actually got this little step
Down here, so you're cutting anterolateral and septum, and that's what you're seeing on the four-chamber view. So that's the line. So part of the RV you're seeing, but you see the big
Cutting it
mass
like that.
of
And
the
so
pseudoaneurysm.
this pseudoaneurysm is actually compressing the RV,
Mhm.
the diaphragmatic portion of the RV
Yes.
wall.
And this is just another image showing kind of how extensive the pseudoaneurysm had become.
Is Isn't it little wide for the pseudoaneurysm?
Pardon me?
Isn't it little wide for the pseudoaneurysm?
Well, no, so that, you know that kind of classic thinking of pseudoaneurysms have a small
Magnet, yeah.
That thing, I think, throw that out the window.
I know, this is
okay?
just-
That may apply for the aorta, if you have aortic ruptures, but for the
not for the
LV,
free walls.
pseudoaneurysms always have a big neck.
It's
Because basically, there's a tear, and then this thing rips open, right? Because you've got high pressure inside the ventricle.
It's
So-
just that it's been sealed off and it's not into the pericardium, otherwise the patient would be dead.
So just
So
a
I
little
presume
bit,
this person had some kind of previous cardiac surgery?
correct, yeah, there had been a previous bypass.
Generally speaking, if they had not had previous cardiac surgery, they would survive.
Mhm.
Okay? The fact that they've had a lot of adhesion from previous surgery is what actually allows them to contain the pseudoaneurysm without immediately dying.
And it had been the thought actually that the pericardium had scarred down and actually was a contained rupture with the pericardium. So just very, very quickly, some information about free wall rupture and VSD. A little bit more prevalent, of course, in the pre-reperfusion era. It's 6% for free wall rupture, 2% for ischemic VSDs. Both of them have dropped below 1% in the current era. Really only present in patients who've had a extensive, have sat on a STEMI, basically. Free wall rupture, the vast majority occur within the first week, very, very rare after 10 days, largely because the tissue is healed some. 40% occur within the first 24 hours of symptom onset. 60+% present just with sudden cardiac death, hemopericardium, and PA arrest. About 30% or so present with, like this patient did, with angina, nausea, vomiting, often with paradoxical bradycardia, rapidly developed cardiogenic shock. Risk factors for these mechanical complications, there's a great publication by Susan Wolanski that talks about this: age greater than 65, female gender, delayed presentation, of course, absence of smoking history suggesting that it's not well collateralized, single vessel coronary disease, the same issue, anterior STEMI, absence of LVH. And if you look at our patient, really the only things that that put him at a risk were his history of hypertension, which is equivocal, really, delayed presentation, which is very important. Unfortunately, he had an unfortunate course. The patient passed away ultimately of septic shock and a very, very big GI bleed, but it's an interesting case nonetheless. Thank you.
All right, so my case I think many people are familiar with. So this is a 30-year-old female. She has end-stage renal disease because of SLE. She's on PD dialysis. She presented from outside hospital with pneumonia, septic shock, and shock liver, and was sent to us for fulminant hepatic failure and consideration of liver transplant evaluation. So she get pre-op echo for evaluation, and that's what her PLA view shows.
Who has not seen this echo before?
First year fellows.
First year fellows, yeah. Come on.
I haven't seen it, so I'll try.
Okay.
I can give you a zoom image.
Oh yeah, I already got that.
Oh.
Severe LV, systolic dysfunction, and there seems to be severe myocardial calcification. I can't even see the valve. The aortic valve seems to be opening, but very, very sluggish, and it's not clear otherwise.
Which one is the aortic valve?
The one on the right.
So this is the aortic valve. Okay.
Nothing strikes you abnormal about that view? You want to go back to the first one?
Yeah,
Sure.
yeah, can you go back? I mean, it doesn't look normal now.
If I know how to do it, I guess. Okay.
Just right-click on the PowerPoint. Oh, you got it.
Yeah, I got it.
So just go through systematically. Talk about everything that you see. What do you see?
So LV wall thickness is increased, eccentric hypertrophy, LV size is severely enlarged, like I mentioned, severe systolic dysfunction, RV function is also depressed, RV is enlarged, and left atrium is severely enlarged. You can't see the walls of the aorta clearly. And
So this is, remember, this is a 5 centimeter. So maybe the LV is less than 5 centimeter.
Yes.
This is also in the LA, and it's probably also like 3 to 4 centimeter. So not that big. I think what's striking on this image is
now where the mitral valve is supposed to be.
right. So this is, these are the leaflet. This is the anterior leaflet, posterior leaflet, and there's, stuff, calcium here. There's calcium in there. So this is what's striking on the image.
Where is the aortic valve? You can see it. Show
And
the aortic
Oh.
valve.
The aortic valve will be somewhere here, open it.
You can see
close
the
it.
leaflet.
You can see the part of the leaflet.
So there's a lot of echo dropout, you can say, right? Can you show where the echo dropout is with the atrial wall and what is there across the mitral annulus? Is it just the annulus that you're seeing? And that doesn't seem. So one option is that you're a little off axis and you're cutting through the annulus, both anterior and posterior. And therefore you're seeing this weird hyperechogenicity towards the interventricular septal wall, just below the aortic. Can you show what I'm referring to?
The intraatrial septal wall.
No, intraventricular septal wall. Can you show that? Yes. What is that?
I mean, it could also be. Oh, there's also a hole.
Okay, so
What?
you're seeing this, so you want to put some color, you want to get a sense, because there's some echo dropout, or what looks like echo dropout between the atrium and the aortic root. Normally you would have an intravalvular fibrosa, you would have your mitral valve, your LVOT, right?
one.
There is some echo dropout there, so.
Yeah.
Yeah.
Yeah. I see it.
But you see, these are things you register. Now, you need more views, you need more scans to see what you're seeing. And what I am seeing to me is, we are used to seeing a very prominent posterior mitral annulus and calcification. Whenever you see it anterior, what looks like correspondingly anterior, it seems to be attached close to the interventricular septum. So I don't think that's the annulus, that hyperechogenic mass-like thing that you're seeing. The only other time you see a very prominent anterior annulus is if you have a ring, things like that. So again, the location doesn't make sense, okay?
Okay. So
So when I see something like this, I would say, is it a unduly prominent subaortic ridge? Normally ridges are not this prominent. You would see it as a linear ecodensity, but not this prominent. So you're thinking of those things as you.
okay.
And
So
there was a pleural effusion.
sum it up: pleural effusion, LA. This is the aorta, LVOT somewhere in here, aortic valve, mitral valve, calcium and calcium. Actually, the next image, the fourth chamber did not show anything different except for the prominent calcification, the LVOT. So I have a Doppler image. Next one. So this is across the LVOT, continuous flow, continuous wave Doppler. So you're getting a very high velocity, almost 4 jet.
Do you have a short axis of the aortic valve?
No, I know.
So we have what seems to be structurally normal aortic valve with a very high.
Well, so couple of things, a lot of missing data here. You don't have color. You want to see where the color flow acceleration occurs, okay? That is a very important clue. When you see color flow, you will be able to see the point at which it accelerates. So you want to see, is it subaortic, is it aortic, is it supraaortic? You want a short axis view of the aortic valve to see whether the valve is opening completely or not. So there are a lot of,
I don't have that short axis, no.
okay. Were they
Okay.
there? Or
We
just
have better
not
than the
put
short
there?
axis echo deposition.
We
He's
have.
still good. He doesn't really.
Okay.
He doesn't need
All
anything
right.
else.
So all I can tell you is there is a fixed obstruction here. What level, I have no clue. I mean, it's going through the, at some point it's a fixed obstruction. Why fixed and why not dynamic? Which fellow wants to take it?
Is it the same
No.
in the book? Or?
Tell me, why is it fixed and not dynamic? Just based on this image.
Because there's no variability.
Mawash. No, what
What
do
she
you mean
said.
no variability? What do you mean by no? What do you mean by no variability?
One, I mean, it's like one, the curve, the shape of the curve is
The curve. It is. It
It's
is.
not dagger.
It's not.
Yeah, you're not seeing the delayed shoulder and the peaking that you would see with the dynamic flow obstruction. What you're seeing, this is a classic of fixed obstruction.
Okay.
So when you see something that's like this, you know you're dealing with a fixed outlet obstruction.
Right, and don't get this, fooled by looking for variability,
Yeah.
right? Because you can have a fixed obstruction, but still have variability if you have PVCs or AFib or whatever.
Right.
Because that's dependent on the flow, right, coming across that
So
location. So it's really, it's the late peaking dagger shape that's indicative of a dynamic obstruction versus a rounded, which is indicative of a fixed obstruction.
Gotcha.
Yes, the rest of the image shows the mass is in the LVOT or wherever classification that we're seeing. So the next that we did was a TEE, and this is the first view.
So Mawash, take this.
So, again, here, I mean, I see, when I first saw the parasternal long image, I thought the aortic valve, surprisingly, was not as calcified as I was thinking. The mitral valve was super calcified. Here, in this one image, I see there is an aortic valve. It seems it's calcified. Now, the degree of stenosis, it does open up. It may be severe, but this image in itself does not tell me if this patient has some aortic or super valve.
Right.
I mean, one thing you could definitely agree that aortic valve leaflets are not opening robustly, they look calcific.
Which is very deceiving on what we saw in the parasternal long. In the
Right.
parasternal long, I almost thought that the aortic valve was nice and thin, and it was opening up very nicely.
What else are you seeing?
Now, what is that area which
Yeah.
which opens up like that? I think of an abscess whenever I see that intervalvular fibrosis.
Yeah, so that is concerning for something like that, right?
So if you wanted to,
So I would do color in that one and see whether there is something there.
I hope they did color.
Images.
yeah, there was no flow. I mean, I don't have the image, but okay, there was no flow through it.
Hearing is not believing.
Yeah, because again, this patient is ESRD, she is 30 years old, she had SLE, she has all the risk factors to have infected endocarditis, and then this is, her valve already looked very abnormal, calcified.
But
mitral
this
valve.
is, okay, so what are you going to show us now? What is causing the,
You're not sure this one?
This fourth chamber on the TE. So the LA and the LV are in RV, and this is the intraatrial septum. And you see the cystic mass with echogenic materials inside it.
I like that.
Your degrees and your, I mean, it's in the septum scope, what could it be here? That would make
it's at the level of the base of the anterior leaflet,
Crux of
right?
the-
And the AV node? No?
Did the vision
No,
have any lines prior?
No.
What is that thing also on the atrial side? There's a little knob-like thing
Yeah,
that comes
those
in.
are almost
So that is
pouches.
very suspicious of, to me, this screams of maybe old endocarditis, healed abscess,
Walled off.
Very unusual location.
very unusual location.
It's not on the valve, right? I mean,
It's not on the valve, it's more in the intervalvular fibrosa.
Okay, so one more image.
Is it?
again,
So
the
two
relationship
chamber.
Is this where you're trying to open up the LVOT as well? Is that?
Two chamber
Yeah,
view.
this is again coming more towards the,
It's a
Anterior.
supposed to be two chamber, LA and LV, and you see it. This, I mean, if you go up on the angle, you're gonna open the LVOT. So
Yeah,
it's
it could be a
at the
stent,
cross of the
those
valve.
very cystic calcified structures like work.
Yeah, so that's how we described it, a cystic calcified structure
It's
with.
not from some like a gynecomastia area that you.
Can it be caseous necrosis?
caseous necrosis, we see it usually involving the posterior annulus
Yeah,
of the
not
mitral
like
valve.
anterior.
Right, I mean, it would be very unusual to have isolated.
Isolated, yeah.
Yeah.
Without posterior involvement, right?
Is this like a gynecomastia or something like?
Yeah, that's another.
Something crazy like that, which, was she from an area where like this?
She was from Mexico.
Okay.
Okay, go ahead, your
Alright.
cheek does, now what was it?
Okay, so what should we do
So
next?
This still doesn't, You have not convinced me about the fixed outlet obstruction. Do we have an answer for that? What is the cause of
I
the
have MRI pictures. It should give us the answer. This is not, okay, it's plain.
MRI fellow?
Okay, I can MRI.
So walk us through the whole thing, how you read your MRI.
Okay, you can correct me, Eric, if you want. I think this is.
I'm sure Dr. Shah will
This
correct
is,
me.
this is our city images, 14. So we see normal LVRD function. Then again in the interatrial septum, again, like this is kind of an opening up a little bit of the LVOT. You see this kind of amorphous structure, and it is seems like it's filled with fluid or blood because it's at the same density as you would see. And then there is a lot of dark structure outside of which could be calcification or thickening. It's hard to say the difference.
But there's no active flow within that cavity.
It
It's
doesn't
No.
seem so, but
Well, so you can't really tell based on this. You'd want to do contrast, see contrast that's inside of it.
Did they?
This is a better view because it
renal, she doesn't get
open up the LVOT,
So
the
this
LA,
person has mitral
LVOT, and
stenosis
this
too?
is- no.
Because the velocity going into the LV from
Yeah.
LA is like, looks like very high.
There is some, and one is you can see there's actually calcification of the
Yeah.
posterior mitral leaflet, right? And the
Yeah.
anus there. And it looks like this mass is also partly adhering the anterior mitral leaflet.
She had moderate.
So there's kind of a pseudo MS picture going on here as well.
She actually
And
had
obviously
moderate.
this mass is really obstructing the outflow tract, right?
Mhm.
So I would suspect that the problem here is not so much at the valve level as it is actually the LVT from this.
So I think her posterior mitral leaflet was also not moving well, and she had like moderate, at least moderate MR, mitral regurgitation.
This view is very good, it shows very nicely the
Mm.
obstruction to the LVOT.
Yeah.
Show it to the people who don't know.
And here the LVOT.
It's almost
Yeah.
blocking it.
So if
It's
you-
almost blocking it, right?
Yeah, exactly. You can see, if you look underneath the valve, you can see a high signal area that's consistent with flow acceleration.
Mm.
Yes.
so that doesn't make sense to my brain because why is the posterior leaflet affected by this process? There's
No, I think that's dialysis.
You'll see
Oh, the-
on the next.
Actually, that could just be.
Yeah, that's incidental. So what was this?
So I mean, the patient did not get gadolinium because she was on decisional disease. So that's the reason.
Did she get
Um,
ferritin?
No.
Because for a case like this, it'd be useful to get ferritin just to see if you get contrast uptake inside of this thing.
Didn't get any contrast. So they decided to take her to surgery.
What
And
was the pathology?
so this is the up note. They reported a mass obstructing the LVOT and attached to the non-coronary and right coronary leaflet.
Just cheese.
And
See that in here. So did we see anything on short axis on TE? How the mass was attached to the LV or
to the
to the leaflets?
leaflet. I think so. The LVOT, the short axis aortic valve was not opening well. That's what I remember. I should have had images, but so basically the mass obstructing the LVOT was impingement of the P2 and P3 segment of the posterior leaflet.
So, but this one still, yeah, that's what. So LVOT, there are two different things they took it out, right? Posterior leaflet was totally different than anterior leaflet. I don't know, the same thing or different thing.
No, this is the same mass.
Was
The
extending whole
location that was extending. So that is what they're saying. It was attached to the coronary leaflets as well as affecting the posterior leaflets of the mitral valve. We'll go back.
It's almost like the crux of the heart,
It's
where
just
you
saying
have the
extensive
coronary and then
Right?
you
This
have
is
the
just calcific degeneration
You're right.
from
That
dialysis.
maybe separate.
With the which one?
Stuff right here, this extensive calcification with, I mean, did they describe this cheesy material anymore?
They
Is
said
that
no.
what they
All they said was like caseous material, cheesy material, and was sent to pathology, and pathology came back as amorphous
So that may
tumor.
not be related to
Not the same
the mass in the LVOT.
It may not be.
It may be completely
Yeah,
separate.
they
That
did
may
not
be
like
from
fully
renal
specify.
failure.
Yeah.
So don't you think though, retrospectively, this
Take one
cystic
second.
mass was just a calcific degenerative process from the renal?
Well, I think certainly the stuff in the posterior leaflet, I mean, the posterior annulus, I think is probably
Not
all
the one
calcific.
that-
The one anteriorly, I'm not sure. I mean, do we have any more path than this?
Pathology.
I mean, for the mass anteriorly, the LVOT mass, is there anything more than?
No, so I mean, this is the visual report from the UPNO, from the
But
surgeon
was it
UPNO.
one singular structure, or like was it?
So it was in separate paragraph. I don't know. I don't have the images. So what they did, they resected the cystic tumor from the LVOT. Because of the involvement of the mitral valve, they could not preserve it. So they resected the mitral valve and put a mechanical valve, and they closed the PFO and they put an ECMO.
We have this patient here, young patient, comes in because of murmur. So let's start with this view. What do you guys see here? Normal, abnormal?
Parasternal long axis. This is weird. Sorry? Same?
So look at the mitral valve.
Yeah.
What do you think is abnormal with this valve?
The anterior leaflet.
Gosh, come on. Senior echo fellow.
Why is all anyone picking on anyone else?
Okay.
Did she have any kind of surgery in the past?
No surgeries, no?
This looks like a very thickened, yeah, it looks almost like a ring, to be honest.
I can tell you it's a native mitral valve, but clearly the anterior leaflet has
But I
some
can see
problem with.
Mawash's
It's
point
like
that it looks like that could be a mitral ring.
I would have opened the
It's
chart
like a
to
hockey
see.
stick kind of.
Yeah, similar to hockey stick, but it's not typical
And
to
there's
a hockey stick.
doming of the anterior leaflet.
Yep.
Yes.
So you do have anterior leaflet doming with systole, you're right. Now what's
Short
interesting here on
axis.
the short axis view to kind of support?
There's only one valve.
Uh-huh.
Correct.
So what does it tell you?
Is it the other one?
It's called parasite mitral valve.
Okay, I heard the parachute mitral valve. That's good. So this is we're looking at mitral valve
It's got a
anomaly,
parachute mitral valve.
where you have a single papillary muscle causing this parachute valve leaflet. So let's go to the other series of images, and this is her short axis view through our aortic valve.
It's a Shone's complex.
Man, what do you see?
Bicuspid aortic valve.
Bicuspid aortic valve, correct, and then
Aortic
your
aneurysm.
ascending aorta was like 4.3. So what is the diagnosis?
Shone's complex.
Shone's complex, great.
Okay, give me all the features.
Okay.
We can hide it.
Subaortic membrane.
So
So
it
that's
can
one.
be so if you start from mitral, so it may be quadratum with mitral
There's a
stenosis.
ridge.
Yeah, there's a
Yeah.
ridge, then mitral stenosis, then subaortic membrane,
Yep.
then aortic stenosis,
Yep.
then supraaortic stenosis, and
Coarctation.
coarctation.
So all left side.
All left.
Yeah, serial left-sided obstructive lesions, great. Rare congenital heart disease described in the old 1960s. Bicuspid aortic valve, although this patient did not have stenosis, bicuspid aortic valve is one of, and you don't have to have all four phenotypic pathologies to kind of label that. Okay, Sean's
Where's
complex.
the supravalvular mitral membrane?
This patient did not have it, only had the parachute mitral valve.
How would you look for a supravalvular mitral membrane? What would you see
Yeah,
if it's
It
causing
would almost
obstruction?
look like a coarctation.
What would it look like?
It would look like a membrane.
Yeah, but
Linear density.
what would make you suspect it? Tell me by echo features, both color and Doppler. So you would have a picture of, you may see a membrane, right?
Membrane.
What is the concern? Is it causing obstruction? So again, it would be a fixed obstruction. It would be like mitral stenosis. So the level of obstruction that you see, so your CW would be helpful, color Doppler would be helpful, depending on how obstructive it is. If it is very rudimentary and not causing obstruction, you're just going to see it as a membrane within the cavity.
And then you determine the whether it's portratriatum versus this by looking at the level of the
Level, So this would just be above the mitral annulus, but it is really schematics, right? I mean, what you're looking at is an atrium that has been divided into two chambers, right? So, but you would look for those kind of things.
Absolutely.
Yeah.
So, Bashar presented a LVOT mass. How about the 17 years old gentleman referred to your cardiology clinic, Mawash, with an ejection murmur?
Like a baby inside the heart.
You're seeing the shard up
It's one of the largest masses.
So just describe what you see. I mean, let's
I see a
kind
ball inside
so what
So,
could this be?
what is the origin? What is the location?
It's in the interventricular septum,
Mhm.
and it's infringing on both the LV and the RV.
Okay.
And you see the flow acceleration because of
Uh-huh.
the color Dawson flow.
And the flow acceleration is almost mid to apical,
Right.
where it approximates, right?
Yeah.
Not as much as in the LVO.
It doesn't obstruct the LV.
Could this
There's
be
no
an
stent
could this
for
be an
that matter.
HCM? I mean, does it look?
That's the mother of all HCM.
If it was very very popular.
Not HCM.
So what would be the next imaging modality if you were offered to pick and choose? Of course.
So there was some flow inside the mass too.
Go back.
If you go back,
to the.
Like if you see in the color doctor, there was some flow.
Inside of the.
That's not,
Is it
yeah, you're
around
right.
the septal wall? It's right. It's yeah.
Subtle,
I can see that.
flow here. So now we're gonna ask our MRI fellows better. What do you describe this as?
There's no other MRI fellow.
Eric, the next question following after the SSFP.
Did see the same thing. I mean, it's a full chamber view. It's
Okay.
bad.
So we need more tissue characterization, is that right? So let's go on to the next. Oh, sorry. So this is a stir sequence, a T2 short tau inversion recovery. I'm sorry. B. And then C is early gadolinium enhancement, and then D is delayed gadolinium enhancement. So, Eric or Butter, do you guys want to weigh in terms of what's the
T2
signals look like?
So T2 indicates bright source fluid build.
So it's hyper intense. Yep, on T2. Yep, you're right.
T2 C shows some really heterogeneous enhancement workouts, mostly. Was this a perfusion sequence?
Say that again.
Perfusion. This is
I unfortunately do not have the perfusion sequence. I only have the early and then the late.
Within a couple minutes after
so
contrast.
started taking out the little contrast.
Uh-huh. So you guys see all this white spots?
Yeah.
So there is some gadolinium uptake in those areas. And then normally we wait like 10 to 15 minutes to look at delayed enhancement, which, do we see any delayed enhancement of the delayed images?
Compared to myocardium, not that much difference.
Yeah.
Is that a long inversion time?
Um,
That's what it looks like.
for the T2?
For the, no, D.
D, myocardium's not.
I don't remember what was the inversion time, honestly, on this.
But it's carrying similar intensity to the myocardial years.
Okay, so what would be the differential in this setting? So we said it's iso-intense on T1, hyper-intense on T2, patchy hyper-enhancement early, and then no delayed gadolinium enhancement late.
Well, no, I don't think I would say there's no delayed enhancement. You can look inside of that.
In the middle.
I'm sorry, here?
No,
D.
it's a D.
Oh, the delayed.
enhancement.
Yeah, you're right. No.
There is still patchy delayed enhancement as well. Because if you look inside of that, there's areas of high signal compared to the lateral wall.
Yeah, okay, I get what they're saying, yep.
I think there's not too much.
Vascular.
So vascular tumor?
Angiosarcoma kind of.
Okay, that's one differential.
Angiosarcoma.
But although angiosarcomas, you're gonna assume
Yeah.
that you'll see more, you're right, first pass perfusion would be helpful if this was a vascular structure.
Or it
But-
could be a myxoma or something benign too, because for a very vascular tumor, you would expect a lot more, right? Am I
Yeah, I don't
seeing
see
this
that
wrong?
much.
How common is myxoma involves the interventricular
Yeah.
septum?
There are
This
some.
would be- But usually myxomas are attached to the wall. This
Wall,
looks
yeah.
like it's within the wall.
Within the
This
wall,
looks like
yeah.
it's invaded into the wall, so I'd be very surprised if this turned out to be myxoma.
Or a fibroma.
No, The fibromas.
So
were
fibromas-
like a
Fibroma.
beacon.
Right, so fibromas have very high collagen content.
Yeah.
So on your delayed enhancement, they would be really bright.
Lymphoma?
How about what looks like a muscle?
So what if I tell you this patient has skin lesions, cafe au lait spots on their skin?
Cafe au lait spots, you didn't have those?
Yeah.
Neurofibromatous.
Not neurofibroma, no. What's that?
Oh, tumors.
Rhabdo?
Tuberous
Rhabdomyoma. It's the most common tumor in childhood. And tuberous sclerosis is very commonly associated with almost 50%. And as Dr. Shah was saying, it's usually hyperintense on T2. There are some patchy early enhancement, but really, unlike fibroma, which is, has a lot of gadolinium uptake late. So this is kind of the main differential. Usually, rhabdomyomas are multiple, and they occur very commonly in, or not as a common tumor in the young age group, and they do regress spontaneously without treatment. But this patient, because of the marked, the large mass-like effect that was causing obstruction, had to take into.
It's asymptomatic.
But isn't this usually regressed by age of 7? This is unusual.
You're right.
Isn't
This
it?
patient was 17 years old, has lived his entire life without symptoms, but
Yeah, this is
now we're
unusual.
detecting
And
this.
this would need to be treated because it's so huge and causing.
So this is a 40 years old patient, history of CVA and polycythemia, presented with an NSTEMI. Unfortunately, I have to open it up in a different window because the videos did not play. But let me open it up here. So what's,
Did you say control L, so the loop?
is there a way to loop
Yeah,
it?
you control L
Oh, control L.
and then play it. Should make it move.
Oh, yeah, great. So what do we see? Let's, Eric.
Heart is on fire.
Okay, so you're concerned about this flow, which looks like in the epicardium? Is that right? Okay. So let's kind of select another image loop. So we're still seeing something in the epicardium which almost looks like a continuous flow. How would you describe it? Systolic, diastolic, or continuous?
It's continuous, which gets more.
I mean,
So,
Say,
you want to know one where the flow acceleration is. This flow acceleration is kind of like in the septum region, and then whether it's both in systole or diastole, and you kind of try to figure out what the origin is, right?
Yeah, so
pulsing this would have been helpful too.
you're right, yeah, which unfortunately we don't have. But we have a an RV outflow tract view here that hopefully can give off.
sometimes the coronary artery aneurysms can do this flow.
Okay, so
And
you're
then-
thinking about aneurysmal coronary flow, which could well be. Let's see. Here.
That's a good one.
Good thought.
and then vasculitis.
So would that be predominantly diastolic or systolic or funny artery aneurysm? Diastolic, right?
I think it.
No, it's good.
I mean, your filling occurs in diastole.
So you are going to have diastolic flow.
This looked like.
You're gonna have both flow, right?
But yeah.
But it would be both because there's filling both in diastole, but more in diastole.
So
Okay.
this is the pulmonic valve over here. What do you guys see? RV outflow tract.
Where's the, oh, okay.
Whoa.
Wahaj, you want to pick up on something?
Yeah, there's this flow.
This jet, where do you think it's,
Coming from this,
is it left to right to left, or what is it?
You're just seeing, what are you seeing? Just describe what you're seeing.
Seeing a
That's the easy way to
centric
start.
jet.
So scan the anatomy here first.
Yeah.
Yeah, okay.
What is, What are the structures?
So.
So the arrow's pointing to what?
RP?
That's the pulmonic
Pulmonic
valve.
valve.
That's the RV of the
RVOT,
tract, and then this is
pulmonary
the
artery.
pulmonary artery.
And what's to the left of it? The rounded structure to the left of it?
Short axis.
Right, that's
Yes.
your aortic valve. Right, so first thing is you want to get your orientation.
So now tell what is the flow that you're seeing?
So from the aorta to the.
Where, I mean, can you say it's from the aorta?
No, not for sure, because it's not originating from the defect.
So this flow you're seeing is going towards the transducer because it's color-coded red. It's below the pulmonic valve, so it's in the PA, and it's coming from somewhere. Okay? However, in what phase of flow this is? You want to slow it down and show them?
Yeah.
Or just tell them?
So if this was a PDA, as Dr. Shah was saying, you would assume that you assume there'll be a continuous flow, but this is a diastolic flow, and
So you should be thinking PDA, but
We're
the
thinking-
phase doesn't match, okay? It's not a continuous flow, it's a phasic flow you're seeing here, and appears to be predominantly in diastole where you're able to slow it down.
The other thing also is a PDA, what is the velocity of PDA flow?
Yes, it's on, what
High
is the
velocity.
velocity?
High velocity.
High velocity.
You should see actually a lot of aliasing.
Which
Go
you're
back
not
to the
seeing.
previous image.
Good point.
yeah,
The Nyquist limit was like 60 centimeters per second. You should have a lot of aliasing.
you're right. Yeah.
And you're not seeing that.
And Eric just raised a really good point when looking at this, the aorta is filling in systole, but see how the flow happens after the aorta.
So it's in diastole.
So it's a diastolic flow.
That's a really good way of.
A diastolic flow into the pulmonary artery. So the next step is an angiogram.
Now who is that cat cell, Eric?
Oh, the people who took the boards know this.
What is filling
So you have antegrade flow through the giant RCA. Okay. Where does the LID connect to or originate from?
It looks like it's coming off the PA.
What's the diagnosis? Great. That's what it is. So this patient has been having recurrent ischemic events because his LAD is technically getting retrograde blood flow from the RCA, and it's originating from the pulmonary artery because the LAD diastolic pressure is higher than the PA diastolic pressure. We're seeing this predominant left to right shunt only in diastole because of that. So you're right. This was a question on the echo board.
Yeah, we got that wrong on boards, by the way.
They always ask.
So this is the
They always ask
LAD,
only
massive
interviews, they
LAD
never ask
originating
keyboard.
from the
No,
pulmonary
on
artery.
echo boards, this was a question.
And then the giant aneurysmal RCA because the RCA now has to feed all the left system. So, if
So
the
it's
time
amazing
allows-
these people do very well till the people who survive, they usually come around 40s to 50s when the aneurysm is so big, and then they started having some other stuff. Because most of the people, we still don't know how they do very well till then because of a big, like neonatal life, they get a big aneurysmal and then all the anastomosis, and that's the whole reason.
I think that's,
Good.
Pretty much
That's
okay.
pretty good.
I think very interesting.
Good job.
Yeah.